Hey everybody, it's Dr. Wood, and today we're going to be covering Chapter 30, actually our last chapter for the semester, and we're going to cover behavioral health disorders. And so you're going to see there's a lot of common signs and symptoms depending on the type of behavioral health disorder that a person has. And so that can include some that you may be feeling right now, right? Stress, anxiety, depression. Some people tend to feel very withdrawn from society, especially when they go in sort of a more depressive sort of phase. That can include hallucinations, both visual and auditory, mood swings, loss of concentration, lots of things here. And so, again, it's an important thing to have on your radar when dealing with patients to say, hey, are you experiencing any of these things? Because it could be that they have been experiencing, they don't really want to talk about it, or no one's really ever asked them before. Because, again, sort of recognition of mental health disorders is still something with a lot of stigma associated with it. Even though it's getting better, it's not where it really should be. And so you can really make a difference as a healthcare provider if you're able to recognize sort of these signs and symptoms in your patients. Now, common side effects. This is a big problem with a lot of these medications, especially if you're feeling depressed or anxious. Some of these medications can actually make these effects worse, or they give you more side effects than what you had before. And some of them may not even work for several weeks before they actually sort of kick in and have any sort of effect here. So because of that, there's a big reason why patients are not going to be compliant with these medications. So for instance, if you're anxious or you may be having depression to where you don't want to be intimate with your partner, that's causing more stress in your life. A lot of these medications can cause decreased libido and impotence, right? Which can further exacerbate the problem. So it's important to be aware of the side effects of the medications you may be prescribing or your patients may be taking and be able to recognize some of these. And in terms of mental health, what we're really meaning is a person's physical, cognitive, affective, behavioral, and social well-being in these cases here. And we're going to find that medications is an important piece, but not the only piece of establishing good mental health. And so it's really important that we try to urge patients to get things like cognitive behavioral therapy and other sort of non-pharmacologic methods of helping to either maintain or help to kind of develop their mental health. Again, there's a lot of synergy between medications and other non-pharmacologic methods, so they work well together typically. You'll find that drugs may temporarily modify the behavior, but you'll find that psychotherapy can sometimes provide permanent sort of changes. Because you'll find that patients with depression, if they are taking antidepressants and they feel better, as soon as they come off of them, guess what? They typically go back right into their depression. So again, it's helpful, but it's not the only thing that's going to be used to help sort of permanently fix their issues. Now, several disorders we're going to talk about here include things like anxiety, neuroses, psychosis, depression, bipolar disorder, Alzheimer's disease, and finally ADHD. So we'll talk about these in more detail as we get to them, but this is a slide you can use to refer back to the different types there. So looking at anxiety, again, medications that we have for this include, or different names for them include things like anti-anxiety medications, anxiolytics, which is sort of the sort of official name for these, or in some cases, these may be minor tranquilizers. A lot of these tend to be sedative agents, and so they do cause, sort of a tranquil sort of effect there. Be careful in using these in elderly patients because you may find they are not able to clear the drug as well, or they may accumulate it, and which means they can have more sedation associated with them. And you never ever want to drink these with alcohol because they can see a lot of excess sedation, CNS depression, respiratory depression, and that can lead to death. Most frequently, you're going to find the drugs of choice include things like your benzodiazepines, and buspirone is another one that kind of fits a different sort of mechanism. Now, your benzos, as I mentioned, much safer than your barbiturates. In the last chapter, we talked about that. However, by themselves, while very safe, they can cause some significant CNS depression when combined with other things. So alcohol is probably the number one thing that I see patients will mix with benzodiazepines. It can cause significant respiratory depression. Patients have either been intubated or they've died if not gotten to in time. And again, adverse effects include things like daytime sedation and amnesia. And actually, the amnesia is actually a good thing for us in some cases. So if we have a patient who, say, comes into the ER, say they're playing football, and now they have, say, a humeral fracture that needs to be reduced in the ER, basically needs to be set, bone needs to be set. They can be very anxious when they're coming in because they're also having a lot of pain associated with that, and they're worried about what's going to happen to them. Oftentimes, by giving them an anxiolytic like a benzodiazepine, they sort of forget the preceding sort of moments there. So that way, when the time they come out of it, they feel better and don't remember a lot of that anxiety. So something that can be useful. We can use that for our benefit, although In some cases, especially if you're mixing with other CNS depressants, that can be a bit of a problem, right? Keep in mind, you will find that if you're using these drugs for insomnia, because again, anxiety is a big reason why patients may be not sleeping well, make sure you only use it for short-term use, maybe 2 to 3 weeks or so, because you will find there is a physical dependence that develops to where they have to use the medications in order to get to sleep. Now, patients who should not be using these include pregnant women because the drugs can be teratogenic, and patients with sleep apnea. These patients with sleep apnea typically are going to be more prone to the respiratory depressant effects of these drugs, and so it's very possible they may just not wake up in the morning because they have basically stopped breathing. And be very careful. Patients with suicidal tendencies, this is a common group of medications these patients will abuse when trying to harm themselves, and then they come into the ER. Some selected anti-anxiety medications or anxiolytics include our benzodiazepines. Common oral ones you'll see being used include things like alprazolam or Xanax, lorazepam, a lot of different varieties here. In terms of non-benzodiazepine ones, Buspar or Buspirone is probably the most common non-benzo one we'll use here. It's also a non-controlled substance, which is nice from that standpoint, and there's not a lot of physical dependence that develops with it. Hydroxyzine, as we mentioned, is another antihistamine that is going to be sometimes useful, but this will be, while a non-controlled substance, it's still very sedating, so you got to be careful. Let your patients know, hey, if you're going to school, you're going to work, don't be driving a car when you're first taking the drugs because you will see that pronounced sedation. Maybe wait until you've had a few doses to where you see how your body responds to it. So next, let's talk about antipsychotics. Another name for these include our neuroleptics. And so you're going to find that these can be useful. So when you have a patient with schizophrenia, taking antipsychotics, normally schizophrenia can present with a variety of different symptoms, but some of the more worrisome ones include the positive symptoms they call, where things appear to be there for the patient, but they're not really, right? They're kind of this altered sense of reality. So for instance, they're hearing auditory hallucinations telling them that they need to go jump in front of traffic, or they need to go, not to go to their job, or, maybe, do illicit drugs or something like that. Basically, these can be some of the ones that are more devastating to the patient, and so we can give them medications to help treat a lot of those symptoms there. And there's a lot of other uses. These are fairly old drugs that we're talking about here that have been used for things like nausea and vomiting, and typically they get classified based on their potency, or basically the strength of the medication itself. So a lot of side effects seen with these drugs, postural hypotension being a big one. And what I mean by that is if patients are going from, say, a lying down or sitting position to standing, their body can have a hard time compensating for that, which means they can have sort of a transient drop in blood getting to the brain, and then that can cause dizziness, can cause syncope in some cases, or them to pass out. And so that can be a concern, especially in older patients. Other things, though, you're going to see is like tachycardia, dry mouth, constipation. And again, if a patient has schizophrenia, they may feel that the side effects are worse than they felt when they were not taking the medication. They may just decide to stop taking them altogether. So schizophrenia can be a really big group of patients who have poor compliance with their medication regimens. Now, long-term use of these medications can cause what we call extrapyramidal side effects. And so basically what that means is it's disrupting dopamine in certain parts of the brain that leads to a lot of movement issues. And so actually we call these Parkinsonian symptoms because patients with Parkinson's disease, they basically are losing their dopamine neurons. And so we're kind of causing a chemical similar effect with antipsychotic medications there. So you can see things like tremors, you can see dystonia, meaning they're having sort of involuntary or irregular movements of their extremities. They can have a hard time actually making movements, and they also can lead to what we call dystonic reactions, where basically the muscles will freeze up in a certain position. You can see this in kids a little bit more commonly. I'll never forget, we have one case of a patient who was, I believe, 8 or 10 months old, got into his mom's antipsychotic medication, had a severe dystonic reaction, where basically all the muscles in his back were contracted to where he basically had this very arched sort of appearance and was in terrible pain. We ended up having to treat that. And just a little side note, actually, you can use things like Benadryl is actually the drug of choice in order to treat that sort of thing. Kid ended up doing fine, but it was a very sort of scary situation for both the child and the mom. Now, we kind of break up our antipsychotics into both first generation and second generation agents here. We're starting to see the second generation agents are being used much more commonly, mainly because they mitigate a lot of those extrapyramidal side effects. They're much safer overall, even though they do have their own litany of side effects. First generation agents are much older. They've been around for a while. And in fact, if you ever want to see a good movie depiction of use of antipsychotic agents, specifically the first generation agent ones, there's a movie called A Beautiful Mind with Russell Crowe. Check that out, and it's actually a pretty good sort of journey through a person's development of schizophrenia, and then actually how the effects that the drugs actually have on them. It's pretty interesting. Anyway, but drugs can include things like chlorpromazine, fluphenazine, perfenazine. Some of the ones we actually use pretty commonly for, say, nausea and vomiting include prochlorperazine or compazine, and then promethazine or Phenergan. I know we've talked about Phenergan previously. And then a very popular one, especially in the ER setting, if we have a patient who's coming in who's acutely psychotic and they're a danger to themselves or others, we can sometimes give them haloperidol, usually through an intramuscular injection that will kind of chill them out for a period of time until you can kind of get them set up for further care. The second generation agents, some of you may have heard of some of these before because they are quite popular, and some of them are actually being used as add-on treatment for really resistant depression. But this includes things like your Seroquel, your risperidone or Risperdal, olanzapine or Zyprexa. One of the big side effects you have to worry about, especially with olanzapine, is weight gain. Patients can put on 20, 30 pounds, no problem with some of these agents, especially Zyprexa. And so again, it could be another reason why they don't want to take the medication. Now, again, when we're using these drugs, the main purpose is to try to suppress these acute episodes of psychosis if they are having one, and then try to prevent any further exacerbations there. And you really want to try to keep them with a high level of functioning such that they can keep a job, they can take care of themselves, they're not abusing or not participating in high-risk situations like illegal drugs or sex and things like that, at-risk sex or like unprotected sex with strangers and things like that. You want to make sure they're keeping high levels of functioning there. Now, getting into depression, this is probably probably one of the most common psychiatric disorders, probably in conjunction with this with anxiety. And remember, for patients with anxiety and depression, they go hand in hand in a lot of cases here. And in fact, one of the first line things you can do for a patient with anxiety is to treat them with an antidepressant. And they may say, well, I don't have depression, but these drugs do work very well for that. And when you feel depression, you feel this intense sadness or helplessness, sort of a worthless sort of feeling there. And again, it could be exogenous, right, which may be reversible, may fix itself over a period of time. Maybe you have a death of a loved one, or you get fired from a job or something. Some of it may be endogenous, where it could be a result of genetic factors. It could be issues of biochemical changes in the neurotransmitters in the brain. A lot of different things that we don't know about depression, which is unfortunate. And honestly, we really don't know how our antidepressant drugs work. We know what they do, but we don't really know how they fix depression. So you typically are going to find the antidepressants will not work within the first 2 to 6 weeks or so of therapy. And again, for a depressed patient, when they hear that, they're going to say, well, why even take it in the first place if I'm not going to feel better? Or if they've been taking it for a week or two and they're like, I don't feel any different and I only have side effects, they may not want to take this. So compliance is another big issue here. Some of them may feel good and they take it for, say, 6 to 12 months and then they can come off of it. That may be fine. Some patients may need to take these for the rest of their lives, right, depending on the case there. The other big thing to note, though, is that any of the antidepressants I'm talking about here, they all have the ability, and they all have a black box warning on them that they cause increased suicidality. And you're sitting there thinking, well, why would I give a suicidal patient an antidepressant if it's going to make them more suicidal? Again, it's just something we've noted in studies, and sort of one of the interesting things is that with patients with depression, sometimes they may have suicidal thoughts and they want to harm themselves, but they just don't have the energy to actually carry through with it. So they may have a plan and they may want to do it, but they just don't have any energy for it, right? Sometimes giving the antidepressants will give them that little bit of boost of energy such that they can then act on those things. So again, you have to be careful because when they're suicidal, you have to screen for that sort of thing to make sure they're not going to show up at your ER, say after a drug overdose or they've tried to hang themselves or something like that. Now, there's 4 major classes we'll talk about here. Sort of going in terms of their age, we have the monoamine oxidase inhibitors first, followed by the TCAs. These are the most dangerous groups of these drugs here. And in fact, if I have a patient who is trying to harm themselves and they take a TCA, that can be one of the most dangerous drugs they can actually overdose on. It can be very, very dangerous because of a lot of the different side effects that can occur because of that. Nowadays, we're starting to use more things like the SSRIs, or selective serotonin reuptake inhibitors, and their SNRIs, or selective serotonin and norepinephrine reuptake inhibitors. These are much, much safer, and in fact, 9 times out of 10, your patients are going to be taking one of these over some of these old school ones. There's still some uses for things like TCAs, like things like bedwetting. You can use them for things like, for instance, neuropathic pain, but by far and away, they're not going to be used all that commonly. Now, some of the side effects you can see with the TCAs include a lot of sedation, dry mouth, constipation. The MAOIs don't get really used much anymore, mainly because of a lot of side effects. They also have a lot of food interactions you can see there, meaning, for instance, there are certain foods that if you were to take along with MAOIs, things like red wine or, say, sausages and different aged cheeses, for instance, they can cause significant side effects and can potentially leave the patient up in the hospital. But nowadays we have the SSRIs, the SNRIs are much safer in overdose. If I have a patient who comes in overdose on a TCA, I'm extremely worried for that patient. If I have them overdose on an SSRI, I'm much less worried because I know they could take an entire bottle of one of these and it's going to be much safer than it would be if it was an MAOI or a TCA. Overall, though, other big things to note commonly is that all of them can cause insomnia, all of them cause nervousness, and sexual dysfunctions and other things very common amongst this group. And I'll talk about one that is less likely to cause that and may be a good option for patients who are depressed and they're taking an antidepressant to get them, say, decreased libido, they develop impotence. This is a good one to switch them over to. So common antidepressants in the TCAs include things like nortriptyline, amitriptyline, doxepin. For the MAOIs, things like phenelzine and tranylcypromine are probably the most common ones you'll see there. Again, this is a group of drugs you're not going to see overall very commonly anymore, both TCAs and MAOIs. But the SSRI is quite common, including things like fluoxetine, citalopram, escitalopram, paroxetine, and sertraline. The SNRIs, and again, these you might actually see being used for certain types of neuropathic pain, like, say, fibromyalgia occasionally, including duloxetine, venlafaxine, and desvenlafaxine. And then some miscellaneous agents include things like bupropion and trazodone. Trazodone is kind of interesting because one of its unique sort of side effects is that one can cause hypotension because it actually has alpha blocking abilities, like we saw in chapter 29, like prazosin. So it can lead to hypotension, but also can cause priapism, which means a sort of unintentional, prolonged erection that the patient can't get rid of. And that can actually be a big danger because it can eventually lead to necrosis and is kind of a surgical emergency. So that's kind of a unique thing with trazodone. For bupropion, you're actually starting to see this being used for other things. This is a good one, though, because it will lead to less incidence of impotence and changes in libido. So if you have a patient who's, say, taking Lexapro and they just either don't want to have sex anymore or they just are not able to achieve an erection, bupropion or Wellbutrin is a good one to switch them over to. And actually, this is another common one you're going to see being used for patients who are trying to quit smoking because it kind of works on dopamine a little bit and kind of helps with some of the reward pathways. And so you may see that under the name Zyban. That's being used for smoking cessation. For bipolar disorder, here you're going to find patients who are sort of vacillating between cases of mania down to depression. And so they have these big wide swings. And so we're going to find that while they're going to be on an antidepressant, that's going to help them with the depressive sort of symptoms. So maybe on, say, sertraline or, say, duloxetine. They're also going to be on what they call a mood stabilizer. So it sort of helps even out the swings between manic to depressive symptoms. And actually, lithium used to be the most common one we would use for this. But unfortunately, there's a lot of drug-drug interactions. There's a lot of interactions in terms of like renal elimination, a lot of side effects associated with lithium. So we use this less commonly now. But in terms of patient compliance, this is also a big deal because when they're manic, they tend to feel pretty good, especially if they have sort of a hypomanic sort of state. They're have a lot of energy. They're cleaning up their their house and everything's super clean and great. So they oftentimes don't feel like they want to take medications, which can be a problem in terms of compliance. Nowadays, though, we're going to see a lot of mood stabilizers that are a little bit safer in terms of their profile. And so this can include a lot of anti-epileptics, kind of pulling double duty here. So, for instance, we have carbamazepine, valproic acid, and oxcarbazepine. These are common mood stabilizers. So in terms of Alzheimer's disease, basically this is going to be a disease state where you have this progressive memory loss and they can have impaired thinking, and sometimes that can even lead them to be unable to perform a lot of their normal daily tasks. So early on, they may be forgetful of where they put their keys, but as time progresses, they may forget how to go to the bathroom by themselves. And so age is probably one of the most major risk factors for this. And so what you're going to find for this disease state is while the medications we have may help to relieve some of their symptoms and maybe their memory is a little bit better, it does not reverse them. It only kind of slows down the progression. There's nothing you can do about those neurons once they're sort of gone. But drugs we have include donepezil, rivastigmine, galantamine, and memantine. The last thing we'll talk about is ADHD, or attention deficit hyperactivity disorder. This is a common thing we're seeing in children, adolescents, and even in some adults where they're inattentive, hyperactive, and they tend to be a little bit more impulsive. And we do tend to see this more commonly in boys than girls, which is sort of an interesting finding there. And so one of the goals here when we're treating patients with ADHD, and it's really important to be very specific about your goals with patients, and it may be very individual. Basically, what we want to do is reduce their hyperactive symptoms, enhance their concentration, hopefully perform better in school or at work, wherever they happen to be performing it. It needs to be individualized to the patient, though. Like, do you want them to be able to sit down after school and be able to do their homework? Are they being disruptive in class? You like to deal with that. These are things you have to talk about with the patient's family. In terms of side effect, though, things you want to be note is insomnia, especially if you're taking the dose too late into the evening or the dose is too high. You see weight loss, which is not great for children who are growing and developing. And as I mentioned, physical and psychological dependence. Okay. There's a lot of interesting news stories that are quite sad, in fact, about patients who are on ADHD medication all throughout their school life, their primary school life. And then as soon as they graduated from high school, they did not pursue college. And basically, the doctors would not give them any more of their ADHD medications. And it was really difficult for them because they developed a physical dependence on the drug after such a long period of time. To be cut off cold turkey was terrible. And some patients even committed suicide because they felt so awful. So it's really important to have a plan for that. Make sure you can taper patients off if they don't need the drug anymore. No, the majority of these, and I'll make note of a few that are not, are going to be Schedule II medications. The reason for that is because they're based off of amphetamines, and they're very strong stimulants. They not only will stimulate things like norepinephrine and epinephrine, they also stimulate dopamine, and that's part of that reward pathway that makes it such that you want to get more and more of that medication. It's part of that psychological dependence on it. When you're dosing patients, unless it's a controlled release where you're going to just have one tablet you're taking a day, if you're taking it more than one time a day, normally do it in the breakfast and then no later than 4 p.m. Typically, they're too stimulated to go to sleep at night if you do it too late from that. We can also do things like lowering caffeine intake from different sources like caffeine and colas that will help, because caffeine plus these amphetamines are going to be pretty synergistic there, so you have to be careful with that. And then we typically like to give patients breaks from the medication. So if they don't need it on the weekend, don't give it to them. If they don't need it during summer break, don't give it to them, because that will help with things like growth. Make sure that's proper for especially school-age children. And again, just less drug exposure is going to help prevent some of that physical and psychological dependence. Some of the drugs we have, including the amphetamine derivatives, include methylphenidate. We have one called sort of mixed amphetamine salts, like amphetamine, dextroamphetamine. This is your classic Adderall. And then a newer one that I see a lot of patients doing very well on is called Vyvanse, or lisdexamphetamine. And so this one's actually a prodrug that's inactive in its normal state. And then once it gets absorbed to the stomach, it goes to the liver, gets activated, and then it's basically dexamphetamine at that point. It works very well as a stimulant. In terms of non-controlled substances, you can use as an alternative includes things like atomoxetine or Strattera. This is actually a drug very similar to the SNRIs that we saw used for depression, things like duloxetine, but it works pretty well for ADHD. And then we also have a few sedative sort of agents, drugs that basically kind of decrease sympathetic activation. And that can include clonidine and guanfacine. And a frequent thing I'll see with patients maybe who are too stimulated by their stimulants in the morning is they'll be on, say, something like Vyvanse in the morning and then clonidine at nighttime. And so that tends to be a pretty common combination. I'm under the stance that I don't like to use drugs in order to treat side effects of other drugs, but for some patients that works well for them. And so, if it's not broke, I say you don't go trying to fix it. Well, that's it for this section. If you have any questions, let me know, and I'll talk to you soon. Thanks a lot. Bye.